Hello everyone, my name's Dr Marcela Martin. I'm an IVF specialist and I'm working in South Sydney, so in the areas of Miranda and Cogra. I've been working in those areas doing IVF and I have been busy making babies for quite some time now, probably good over 15 years that I've been doing specialist private IVF work. So I would invite anybody to ask me any questions this afternoon regarding anything about their IVF journey that they might have, or their fertility journeys per se. I'd like to particularly focus on IVF in terms of egg freezing, if you've got any questions about that, and also embryo freezing, if you've got any questions about that. So if you've had your IVF journey and you've got any questions in particular about your outcomes, I sort of welcome and invite you to ask me some questions. But let's talk in general about IVF to begin with. So in the beginning, I guess IVF was just used by people who were struggling to have babies, but we can do IVF for all sorts of reasons. Sometimes we're doing IVF because we need to rearrange our life plans. So we might be trying to make some embryos, bank them away so that we can carry on with other factors in our lives, be that further education or further work prospects, but also balancing the fact that you don't want to leave making babies too late. There's quite the difference between having a baby and perhaps using IVF as a tool to try and preserve your fertility and control your family size in the future. So I invite people to think about things like that. Also with egg freezing is a little bit more obvious. It's becoming a lot more feasible for women to stop and consider their fertility potential and think about freezing some eggs. We've become really good at doing that these days, and then thinking about in the future whether you need to use those eggs at all. So some women will freeze some eggs maybe in their early 30s, bank them away. They may or may not find a partner later on in life, and if they haven't found a partner, they've still preserved some fertility options. They might find a partner and fall pregnant all on their own, but they've banked themselves some eggs as a backup plan. So as for women, it's a way of sort of looking at all their options and not necessarily having to settle in some cases just for the sake of having a baby. So I've got one question here. Do I have better success by freezing eggs or embryos? Thank you for your question, Julie. So freezing eggs and embryos are two different strategies. While the technology and the techniques to get to that endpoint are very similar and they both entail an IVF cycle, freezing eggs is quite different to freezing embryos. An embryo is an egg that has been fertilized by sperm. So we've already know that that egg has the potential to fertilize and divide and make a day 5 embryo, what we call a blastocyst. So it's gone through jumped through a lot of hoops to prove its worthiness by the time we freeze a day 5 embryo. So the chances of success of a pregnancy down the track are much, much higher. As opposed to an egg, when we freeze an egg, we don't know the potential of that egg. We don't know what genetic secrets it contains. We don't know whether it will be a good egg for fertilization. That egg in the future, if you go to use it, has to survive the thaw process and has to then show its ability to get to get fertilized by sperm and then to have division as well. So all of those hoops haven't yet been covered by a frozen egg. So the success rate is undoubtedly much better with frozen embryos. But of course, you need to be at a point in your life where you have a partner, so you've got sperm to freeze in order to move forward with that embryo in the future. We've got another question here. Kath has asked, last round of IVF, I got 4 eggs but none fertilized. This time that she's used the same drugs, just a slightly higher dosage, and on day 9, scan and bloods, there was no follicle growth and estrogen was low. So we've had to cancel that cycle. So that can happen. Sometimes if you go too quickly from back-to-back cycles, you don't get a great outcome. So generally we would let the ovaries rest for 1 month on, 1 month off with IVF, so that we don't get a mixture of signals to the ovaries. So that could be one thing. But the ovaries sometimes it's like catching a good wave. Even though you might be used to how they behave to a certain drug and a certain dosage of drugs, but from one cycle to the other, there is variation within one woman. I wouldn't give up, Kath. That just sounds like that. Unfortunately, on that scan, the ovary just didn't want to play at that particular cycle. And as disheartening as that is, it's always worth just rethinking whether you could do a little bit better. But the fact that you got 4 eggs and none fertilized makes me want to ask a few more questions about the eggs. It might be worth that while a higher dosage might get you a few more eggs, it's still the quality that matters. And perhaps we need to think about, are there any other factors with the egg quality? Looking at age the older we are, the harder it is to get a good quality egg. And sometimes if we're getting no fertilization at all, presuming that the technique of fertilization wasn't an issue, we sometimes look inside the egg with a microscope called the pulsoscope at IVF Australia to sort of get more details about the matrix inside the egg. Is there something continuously telling us that the matrix inside the egg is a problem? That might help you decide about moving forward. The risks, I've got another question from asking about what are the risks of freezing embryos and how does the thawing process work? Well, that's a great question, thank you. The risks of freezing embryos, well, there's always a potential that that embryo will not like the process of freezing, will not survive the freezing and thaw cycle. So we generally quote people about a 5% chance that the embryo will not wake up when we thaw it. Thankfully, it's a lot less than that in reality, I think, in experience. But once in a while we might get, in particular with one patient, we might get a recurrence of failed thaws, and we ask ourselves, is that more a matter of the quality of the embryos? But generally, yeah, I guess the worst sort of quote we would give is around about the 5% mark. But thankfully, techniques have advanced so much that we're getting a lot better at freezing and thawing the embryos. And we actually use a technique called vitrification, which is rather than freezing per se, but we use the same terminology, I guess, on day-to-day speaking about these things. The other thing is how the embryos are kept. So making sure that the embryos are kept in a good quality laboratory with good security around those precious little things, and good temperature control and good safety control as well. I've got another question here. So Brad's asking about his wife who was put on estrogen for a frozen embryo transfer, and her levels were at the 700 mark. During the cycle, while taking estrogen, they dropped to 350. Now, by taking estrogen, Brad, sort of the question becomes, so I'm presuming that she was put on hormone replacement therapy. That can be a little bit hard to monitor the estrogen levels. Well, in actual fact, if we're putting your wife on tablets to keep the estrogen levels steady, there really isn't much of a purpose of doing the blood test, because really that should be steady all the way through. So one of the common ways of giving estrogen is Progesterone. We would use that, say, in someone who's struggling to make any estrogen themselves. Otherwise, we would generally allow the woman to do a natural cycle. One of the great things that we can do at IVF Australia is that by doing natural cycles, of course, that means that someone could end up needing the embryo transfer at any of the 7 days of the week, and we're open to do embryo transfers 7 days a week, so that's fantastic now, and that's allowed a lot of women to just go on a natural cycle without extra estrogen supplements. So another question I have is about polycystic ovarian syndrome and whether you should freeze eggs. Well, I think the key question with that is really lifestyle issues and where you're at in your life and whether you think that's a good investment, but also your age. So the polycystic ovarian syndrome as such is not the major issue. It's not going to make you run out of eggs any sooner, although sometimes you can't help but fear that some girls with PCOS don't get any periods, and so you can't help but worry. So if someone's labelled you PCOS, make sure you've had your AMH level done, that blood test, so nobody's making a mistake. So PCO girls would generally have good AMH levels, just to make sure no one's confusing that with you're running out of eggs, which can present with no periods as well. So always tick that box. But freezing eggs just because you got polycystic ovarian syndrome is not necessarily the key issue here. So the good thing about PCO girls is that they generally can be well stimulated to freeze eggs if they want to. They generally have a really good outcome. Nikki's sort of added the fact that at 36 she's been thinking about freezing eggs. 36 is a good age. Ideally, we do it 35 or under, just as a general cutoff, because we know the quality of eggs starts going down, it starts deteriorating after 35 at a faster rate with each year. So I'm not saying 36 is old at all, Nikki. 36 is a great age to actually freeze eggs. If you're going to do it, get on with it. Think about putting that money aside, freezing your eggs, and you've got that investment then. Yeah, I think that's a great option. I've got a question from Craig saying we had a really good embryo that didn't survive the thaw. So, can the cause be determined after the fact? Well, generally not. Generally that embryo perhaps just didn't have the genetic makeup to take it to the next stage. Very rarely do you have an embryo that doesn't make it from a technical point of view. We're very careful about these embryos coming through. So as I said, it's rare that the embryos don't survive, but really you've got to think about the fact that if it wasn't good enough to get through the thaw process, it probably wasn't going to give you a baby, a successful pregnancy. I've got another question here. What are the chances of a successful IVF ICSI cycle when there's a male factor involved? So something to do with the sperm is not helping you get across the line. Sometimes I'll use this as an example of discussing those cases where we get really, really, really low levels of sperm. That can be really tricky because not only is the level of sperm, the numbers of sperm really low, but generally the quality of sperm is also low as well. So two things I would ask Lara, or encourage Lara, if this hasn't already been done, is think about getting the DNA fragmentation information about the sperm. So that your doctors should have ordered probably has ordered, I should say, a test to look at the internal part of the DNA of the sperm, looking at whether there's lots of breakages in there, and that might give you an indication of how much to pursue this. But also looking at whether doing a high digital magnification of the sperm when selecting sperm to put it into the egg might improve the choice of sperm that you put into the egg during an ICSI cycle. So high digital magnification would probably be the way to go if it hasn't already been tried. The other thing, of course, Lara, you might want to think about is sit down with your specialist and think about whether we should be, why exactly is the sperm low, but is there a reason to actually, rather than just use the sperm that is obtained through masturbation, but rather maybe we need to think about going straight to the factory into the testicle to retrieve sperm that's at a different level of maturation. So that's quite a complex conversation to have with your specialist. So I've got another one where we had a failed thaw, a good quality embryo last month, and no one knows why. So how do you know if it's safe to freeze future embryos? Would it be more likely to happen to us again? No, I think it's a roll of the dice. I really do. These things happen, and it's heartbreaking when it does happen. I would ask whether you had a few embryos, and did you have a big batch of embryos, or did you have just one embryo? So certainly if we're really struggling to get embryos, that might be more to the nature of the embryo itself. And one batch can be quite different to another batch, even from the same woman and man, not two different times. As I said before, sometimes you just catch a better wave in those, and you get better quality eggs from one cycle compared to the other, even if you do almost the same thing. So I wouldn't lose heart. I would say, well, you're getting embryos, you'll get there. I would look at that as a positive thing. So there's another one that's a question here from Violet. Violet's asking, why won't some doctors do embryo transfers if their eggs aren't at blastocyst stage? So you had 10 eggs, Violet, and 2 made it to blastocyst stage, so the other 4 embryos were discarded. Okay, Violet, it's really important that you have a good understanding of this. As heartbreaking as it is not to get more embryos on day 5, think about this. The whole day 5 process that you're doing is about weeding out those embryos that aren't good enough to give you a baby. This is all about putting a live baby in your arms. And we're using natural selection, or that growth phase, to sort of get the ones that are only just not going to get you, less likely to get you pregnant, or end up in a miscarriage at best. So it's better that we take that out of the picture. I know that some places might consider doing a day 3 embryo versus a day 5. Personally, I like to push embryos to day 5. I like the embryo to prove that it's worthy enough to go into your body, because otherwise it's the woman that sits by worrying about waiting for that pregnancy test for 2 weeks thereafter, after you get the transfer, and that's really really demobilizing, and can really make it a really difficult journey, those 2 weeks. And if we're not putting something that's a good high quality, I just don't think it's fair to you. So your doctors are just trying to give you the best chance. The other ones, they literally disintegrate. They're not going to do anything. They're not going to give you what you want, which is that baby. I hope that helps, Violet. What is the maximum storage time for embryos? There is no actual set limit at the moment. There used to be an arbitrary 10-year limit, but we're past that now, and that's more I guess a state government sort of decision, but at the moment we haven't reached those limits. The longest time between making an embryo and delivering a baby, because I also deliver babies as well, so putting an embryo in and then getting the privilege of delivering that baby, for me personally, has been 10 years, and that's someone who was wise enough to make some embryos before they underwent some chemotherapy. Thankfully, 10 years later, they were free of their disease and they went on to have a beautiful baby. And that's happening more and more now. These embryos are frozen in time, so even though the woman might get older, she still has a chance of being pregnant, like she at the same success rate of the age of when she made that embryo too. So that's another fantastic thing. So the other thing, question I have here from Brad again, after how many failed transfers do you look at the changing the cycle, or proceed to do more tests to look into the reasons why we're failing? Well, I think each and every case is very different. Personally, I like to do a lot of tests at the beginning so that I'm confident before I even start the cycles. I think most doctors would agree with that. Depends on what sort of things get flagged when we're taking histories, and how far do we push the sperm examination versus the egg examination. And certainly the general gist is after about 3 IVF cycles, most people have achieved their goal. Then there's that subgroup that ends up needing to do more and more cycles. And that's when we need to bring the higher level of technology in. I certainly wouldn't be doing 4 or 5 cycles at sort of the simple style of cycles that you can get in some places. Certainly when if you haven't achieved a baby after 3 cycles, you want to make sure you've really ramped up on technology. And by that I mean, is there a pulsoscope you should use, a high digital microscope? Are we looking at the problem from the egg or the sperm? And what kind of how are we growing those embryos? Are we using a good quality embryoscope in the laboratory that you're utilizing? So always ask those questions about your laboratory. I've got another question from Tiffany. I'm 35. I had a failed fresh transfer and I'm waiting a month to have a frozen transfer. I guess the question is really the chances of frozen versus fresh. And do you recommend a blood test to check the progesterone levels? Well, the way I would do my fresh and frozens, we would always be checking for progesterone levels and estrogen levels and scanning you during a frozen transfer, because we want to know 3 things. So most of the cycles we do are natural, I guess, or with a little bit of hormone of those injections, those FSH injections you use to make your embryos, if you're not great at making good lining on your own. So what we're looking for is that trend in your LH surge, so we know your body's getting ready to ovulate, but then we count 5 days later if we have a blastocyst and we put it in at that. And because that can fall anywhere on the 7-day cycle, as I mentioned before, we have to be prepared to meet you at the lab to do that transfer on that day, which is tricky, but we all try our very best to make sure that happens. But certainly in a cycle we would be doing progesterone levels to make sure that it's at the appropriate level when we're doing our pregnancy test and then carrying on for extra progesterone support. If your question refers to day 21, most of us won't need to do that because we've already seen the LH surge, so that precedes the day 21 progesterone level, if that's what you're asking. And most of us will give extra progesterone support anyway, so perhaps that's a superfluous blood test if you're talking about day 21. I hope that helps, Tiffany. Oh, and the other part of your question is success rate. Well, I'm pretty happy with success rate. Fresh versus frozen, I think in our laboratory these days, that's an equal thing. I'm never afraid to do a frozen transfer. In fact, in a fresh cycle, I will quite comfortably freeze all my embryos if I do not think the lining is perfect, or if I think there's a risk of ovarian hyperstimulation. There's just no pressure anymore to be always going fresh. Fresh is not always necessarily best in every cycle. So I'd be really optimistic about your frozen cycle. I have another question. I'm 37 and I'm supposed to have in my first cycle. Well, good luck with that one. My FSH is 24, so my specialist cancelled my cycle and we'll try again next period. You can't, and so the question is, can I improve my FSH level? So because your FSH was a little bit too high to start, you won't get a good IVF cycle. So your specialist is trying to make sure that we start at the right time. If you're at a phase in your life, which at 37 I'd hope not, but if you're at a phase in your life where your cycles are so irregular that you're running out of egg reserve, then having a high FSH level just doesn't lead to a good down the track of your stimulation of your ovaries. So I would agree with your specialist. I would have cancelled and not started and just gone no, let's just be patient one more month for the next period. Make sure you're having your levels done really early on. So at IVF Australia, we do day 1 bloods to try and make sure we're not, wasting your time at the start of an IVF cycle. So we do that all the time. As difficult as the logistics can be to do a day 1 blood, I do think it helps us cancel less cycles down the track. So yeah, good luck with that one. Tiffany's asked, would you recommend a blood test a few days after transfer to check the progesterone level? No. I see your question now, Tiffany. No, look, not necessarily. Everything should have been set up so that there's no need for that. So it's the way the cycle's set up. So I would chat with your specialist and ask, why are they confident that progesterone levels are up? That might help you get to a level of confidence in the style that you're going through. I hope that helps. Yogi's asking a question. My wife is 37, AMH of 5.7 and has endometriosis. The chances of IVF? Well, Yogi, there's going to be so many other things that are going to affect your chances. But endometriosis is one of those things that we're yet to fully understand, and it depends on the level of endometriosis. We know that endometriosis, especially if endometriosis is occurring on the ovaries, can literally steal some of the fertility potential from your wife. As unfair as that is. And so can repeated surgery, because every time we're going in to do surgery, we might be taking some of those, those chocolate cysts that you get in severe endometriosis, that cysts that are just full of old blood. That destroys ovarian tissue. And so generally these girls will have a lower ovarian reserve. So at 37, 5.7 is a level where I would certainly be saying, yep, you need to think about investing in getting eggs out of there, making embryos, banking them, and getting on with pregnancy if that's appropriate for where you're at in life. Hopefully the pregnancy itself will improve the endometriosis, plus you've got some embryos frozen so that if her egg reserve goes down to 1 or makes it really difficult to get pregnant in a couple of years' time, when you're thinking of baby number 2 perhaps, then you've got a backup plan in the freezer. That's where frozen embryos becomes a fantastic resource. It's always hard for people to look beyond getting pregnant the first time, but one of the questions that I ask my patients is, what sort of family size are you hoping to achieve? It's not always possible to give you that second baby, but we need to think about strategies so that we can freeze the hope for that second baby as well. So the success rates at 37 would certainly be better than any other age. So with that AMH and that endometriosis, I would definitely move forward with that, Yogi. Amy is asking, what are your thoughts on recurrent implantation failure? And what sort of things do you consider if there is a clear uterus and no clotting factors? So obviously you've had that, what we call the thrombophilia screen, that really big long blood test that you go through, and it only picks up rare sort of small minor things that we for clotting factors. So obviously you're normal for that, and you've had someone look inside your uterus to make sure there's nothing abnormal in the structure, there's no polyps, etc. If the uterus is clear, you must have had a hysteroscopy as well, or at least a high COSY, so a scan with actual contrast. So bearing all that in mind, the next line of things that we sometimes look at is the immunology of things as well. So we certainly look at natural killer cells and think, is that an appropriately balanced level? So natural killer cells are like surveillance cells in the uterus. They're meant to be there. They're trying to protect your uterus, but at the same time they can be a little bit overactive and stop you from holding on to a pregnancy. So there's a blood test that we can do for that, and sometimes we do a biopsy of the uterus as well. So that might be something worth thinking about as well. But also, if you've had lots of embryos put in as opposed to recurrent miscarriage and spontaneous pregnancies, it might be worth doing genetics on those embryos. If you've had quite a number of high quality embryos going in, they're not getting there. We've got to ask ourselves, what are the genetics of these embryos? So I've had cases where I've seen people have 8, 10 embryos put in, and I'll ask, what's the genetics? And it surprises me when sometimes these questions haven't been asked. And it is really important at that point to maybe do a cycle with pre-implantation genetic testing. That may help. So I hope that helps you, Amy. Good luck. Catherine's asked, I heard ovulation can occur hours to days after LH surge. So how do you know when to transfer a frozen embryo based on the LH surge in a natural cycle? Well, we don't just rely on the LH surge at all. We're looking at the pattern of estrogen as well. So on either side of the LH surge, we'll see changes in estrogen levels, and we'll also see changes in progestogen levels as well. If sometimes it gets to the point where I might end up having some poor person do two to three tests in a row, because it's that pedantic that we're moving the barometers, because it will make a difference what day you're coming in for your transfer. And we're using the ultrasound as well. So let's not forget, we're looking for that follicle, we're looking for that change in that follicle. So you might have a nice follicle and then suddenly it's gone. So then we know those things are all in keeping with the LH surge. Plus, we're also looking at the lining. So sometimes we can get good hormone levels, and I'll be astounded to find that the lining is really thin. It's continuously 5 millimeters or 6 millimeters, at which point the chances of your embryo stinking are dramatically decreased. So we wouldn't thaw a good quality embryo. We'd go back to the drawing board and ask why. Has there been damage to the lining in the past for whatever reason? Maybe surgery, maybe a miscarriage. We've got to ask ourselves why. All right, so the next question is from Kimeng. I hope I pronounced that right. I'm 42 and have multiple fibroids. 2 of these are intramural and both measuring 4 centimeters. Do you think mini IVF suits me better than traditional IVF? Does mini IVF reduce the chance of women's uterine fibroids becoming larger after stimulation or injections? Well, with fibroids, yes, they get fed by estrogen, but with the IVF cycle, the rise in estrogen is short, sharp. It's not like as if you're on estrogen for months and months and months at a time. Right? So I don't really think it's going to have a huge impact on your fibroid growth. My biggest concern is your age and getting good quality embryos. That is going to be our biggest struggle, and I certainly would not wait for embryo. So if you had a problem with your fibroid and you had to have surgery for whatever reason, it's grown into your cavity, etc., I would still go ahead and make those embryos, because we can always go back and correct the uterus if we have to. And that's a complex statement, because that kind of surgery is fraught with difficulties, but the window is closing fast on getting eggs out and being able to make embryos. So I think that far supersedes that, and therefore mini IVF I don't think is good for you, because you need to get as many in one hit at a time, so that we can then have a chance of making an embryo that makes it to day 5, and at 42 perhaps consider genetic testing on those embryos, because of the risk of abnormalities as we get a little bit older and fade. So there's a few challenges there, but I would certainly put harvesting eggs as quickly as possible way above worrying about the fibroids at this point in this age group. I hope that helps. Good luck. So the next one is, how much does progesterone pessaries affect serum progesterone levels, and are they reflective of the body's natural progesterone, or will they be higher? They're generally a bit higher, and different people will absorb different pessaries differently. So, for example, when we do a pregnancy test on somebody, we will always measure the progestogen levels, and sometimes we can be surprised that the progesterone levels aren't as high as we'd expect, even with the pessaries. Those girls, I'll definitely keep the pessaries going until their next pregnancy test. And and the so for those girls, yeah, so I would definitely keep those progestogen supplements going. So next question. Violet has asked, can I use progestogen injections self-administer instead of pessaries? I'm having a bad reaction to the pessaries. Okay, all right. So Violet, I would take note of all the different pessaries that you may have used. We don't have progestogen injections in Australia, so we can't use those injections. But sometimes we use pregnal injections instead. And so with pregnal injections, you use one before the transfer and two after the transfer, and that's sometimes what has to be done. Okay. So Sarah's asked, Sarah's just sent, hello, a beautiful little boy Jackson. Excellent. Thank you, Sarah. Thank you very much for sending that message of support. Now, where else have we got? Amy's asked, Doctor, would you consider older ladies 40 plus who have good follicles? Of course, we would always consider every woman's individual circumstances. We know that all the bells and whistles of IVF make we're not that great after the age of about 42, definitely not after 44, and so we've got to weigh up whether the technology will or won't improve your chances compared to falling pregnant naturally. Let's not forget, women fall pregnant naturally at all different ages. But the question is the technology going to improve your chances? That's a very different statement. So I always think it's worth sitting down and chatting. I also think it's important for women. So some women, even though you tell them that the chances of success are very low, it's still an important part of their journey to make sure they've given it a go. So if that's the chapter they're then going to close, that's an important tool as well. So IVF can be that important tool. You have the right to ask. And if you're getting follicles and your AMH is there, the one thing that we can't do, of course, is improve the egg quality. So if we're getting eggs and we just keep harvesting them, we may get lucky. So that you probably are a good candidate to give things a good going. And the other question I have here from Catherine is, how high should a progesterone level be before stopping progesterone pessaries? So that it's no one sort of set number that we would go for. So what's more important is making sure that you're not reacting badly to any pessaries, and also making sure that sort of this. So if we're sitting there with a progesterone level of about 100, then we know things are pretty safe. I'll answer your question another way. What we're trying to do is try and keep the progesterone levels above 20. If the first natural progesterone level, say on a natural cycle, is really low, I'd use that information to sort of say, okay, we're probably not going to move forward with an early bite with this pregnancy. It's probably not going to end well. It's probably going to be a miscarriage or biochemical pregnancy. So there's a role for just measuring the natural progesterone levels, especially if you've got patients that have recurrent miscarriages, because we can prevent some heartbreak down the track. Flip side of that is sometimes you just want to control it, so there's just one less variable to worry about those first couple of weeks. So what I would do, if someone's pregnant, I measure the beta-HCG and progestogen levels and decide whether that individual needs progestogen pessaries, or we stop them, do we reduce them, do we increase them, do we swap the brands around if they're not happy with one particular type. And then I do another one 48 hours later, I want to see that beta HCG rise. I want to see that progestogen nice and stable. And then I'll do one a week after that, and the following week I'm doing an ultrasound at 6 weeks. We get there pretty quickly. There's variations to that program. Some people, their levels look so good, I'll just go, stay on exactly what you're on, spare yourself that extra blood test. I will just do a blood test next week. They're the ones I usually feel quite confident, and that's always a good thing. Next question I've got is, how long do you need to take prenatal vitamins before you can begin your IVF cycle? Is 1 month long enough, or would I need to wait longer? 1 month is generally good enough. Because let's not forget that when we're doing the IVF, you're not going to be technically pregnant to the 3rd week thereafter, so that's very close to the 2-month sort of advertised amount that you often see, but 1 month is enough, so that's generally pretty good. So Gordana's asked, what is the best time to inject Gonworth, morning or evening? It's up to what works for you, what works best with your work situation, etc., with your timing. I'm not picky about that at all. Morning ones are good in that that we're measuring, because you go to work and you can just forget about it, it's done. Because one thing we really don't want to miss out is your FSH injection. However, the advantage of doing it at night time is because we'll get our results in the middle of the day, so we might sort of change things around. And so if you haven't had your FSH injection that day, that night one might get bumped up or brought down. So really, it's the more important thing is how you're going to remember your injection and how does that fit in with your lifestyle, work, and all those sorts of things. The next question I have is, does the type and method of culture media play a big role in embryo success? And what are the risks of PGS on an embryo? And could it damage the embryo? Yes, it could. So let's start with the second half of that. With the PGS, so if we're taking a little cell from the embryo to then crack open that cell and look at the genetic contents and find out what secrets that little embryo has, then we are physically doing something to that embryo. So you could potentially damage that embryo or lose that embryo. So then it comes down to how good are your scientists. And just about everything in this story is always down to how good are your scientists. So we have a really high premium level of scientists. They're trained very highly and they're always practicing as well, keeping their skills up to date, which is makes us very confident about our scientists doing the biopsies. But yes, there's the potential to damage them and lose a good embryo. So PGD is not the answer for everyone, and it shouldn't be done across the board on everything. We thought initially that that might be the case, but it hasn't turned out to be this magical test. I personally do a lot of monogenic testing on embryos for different diseases, so especially when couples have had an affected child with this particular illness. So I would tend to do a fair bit of T and PG testing for monogenic genes. The medium is very important, and that's something that's set at the laboratory level. So we have constant meetings with our laboratories. We have a very diligent scientific officer that will present to us any changes, always monitoring everything from temperature, lighting, how many times the door is opened, all these sorts of things, all these things that could potentially affect function in the laboratory. So it's really about your lab, so that is very important. Ask those questions. The next question I have is looking at when you start your IVF cycle, and have to go in to do blood tests every couple of days. Does it matter if you do the tests in the morning or afternoon? Oh, very much so, Kate. Thanks for that question. Has to be in the morning. So we tend to do things really early in the morning, but it's a matter of, because we want the answer in real time. So we'll have noted when you're taking your injections, all of that will be in your file, so that does help us make decisions. But it's really important that they're done in the morning, so that by lunchtime the nurses and I are having a meeting about your results, and then we can delegate the nurse that's looking after your case to then have enough time to be able to communicate with you. What's the plan? In a couple of days' time, do you come back? Are you ready? Do we pull the trigger? And are we ready for egg collection? So it's the logistics of being able to provide you with the next step in real time. Otherwise, if we did bloods at night, then we wouldn't get the results the next day. But your body's different the next day, so we can't guide you. So Kelly's question is, how do we, any advice and recommendations on achieving success after an embryo transfer? Well, the things that we generally tell our patients when we're putting an embryo in, it really is up to the embryo at that point to do the next thing. One of the things that I try and encourage my patients to remember is to just keep living their life, doing the things that make them happy, go to work, don't lie around thinking nothing but that embryo, because that's going to stress you out, that's going to raise your cortisol levels, stress you out, and that cannot be helpful in trying to help you achieve your goal of pregnancy. In fact, they've actually done studies long ago where they've looked at whether it was better to lie someone down for 2 weeks or keep them active, and the data is overwhelming. Just keep active, keep living your life. Right? Take your mind off it. Pretend you just gotten pregnant the traditional way, and you'd be none the wiser. Carry on. Easier said than done, of course. And sometimes some of the tools that we have to help people are counsellors as well, so that you can help and feel confident and not be bogged down by anxiety about the impending pregnancy test. So surrounding yourself with good people, eating good food, staying healthy, doing the things that you like. Exercise is fine. If you're a high intensity sort of elite athlete, generally we talk about what particular events they may have. I've been involved with some elite athletes before, so they're special cases that we might discuss in more detail about how their level of training. Well, that is a lot of questions today, and my goodness, time has just moved on. So I'd like to end the feed now. Thank you so much for your time and sharing your questions with me. I am more than happy to take any further questions personally and chat to you. I consult out of Cogra and Miranda. I also do obstetrics, so I have the pleasure of sometimes seeing my patients all the way through, which I absolutely love doing. But if you live far away and you still would like a consultation, we're in the era of Zoom, so I'd be more than happy to Zoom and sit down and go through things with you. I often ask that you send me some of your information first. My secretaries will take care of that, and I can look over some of your cases, and we can sit there and Zoom and chat one-on-one about your particular circumstances. Anyway, have a good night, everybody, and thanks for your time.